Hello, everyone. Welcome to the Emory MCI Dementia webinar series. We're really glad that you're here. For those of you who were here last month, thank you for your patience, and we apologize for those technical difficulties. We were just chatting before that we were all actually comforted to learn that it was actually a Zoom server issue that we had no control over rather than user error. So thank you for coming back. This is going to be a fantastic presentation today. My name's Ashley Varner, and I'm a social worker here in the Cognitive Neurology Clinic at Emory. I'm joined by my colleague, Jenny Gay, who is a social worker in the Integrated Memory Care program, and Debbie Arnold, who is a social worker in the Cognitive Empowerment program. This is a monthly webinar with topics relevant to people affected by mild cognitive impairment and dementia, both those living with cognitive change and personal and professional care partners. Previous webinars can be viewed on YouTube at https://bit.ly/dementia videos. And I'll go ahead and put that in the chat in a few moments. Since it is a webinar, the audience can't be seen or heard, but you are able to put questions in our Q&A section. So please do that. We really encourage you to do this, and we'll have time at the end for questions and perhaps all the way through. Today, we are incredibly fortunate to have Debbie Gunter with us. Debbie is both a hospice and a palliative care and family nurse practitioner here in the Cognitive Neurology Clinic at Emory. She has been here at Emory for 19 years now and was one of the founders of Emory's palliative care program before moving to cognitive neurology about 9 years ago.
True.
Is that not true?
No, I said true.
All right. She is one of the foremost authorities on palliative and hospice care for individuals affected by dementia. And she's just really a terrific speaker and asked to speak all over the country as a result. So we are really lucky to have her today. And with that, I'm going to hand it over to you, Debbie.
Well, thank you. It is always good to be with this fabulous group of social workers and all of the work that they do. They hear me as well as the rest of our team, both cognitive neurology and CEP and the Integrated Memory Care Clinic, to say that we are just also so fortunate, so blessed to have a team of social workers. Because not one person cannot do everything. And so this webinar series is so wonderful as well. So it is always good. And thank you for the opportunity to be able to talk. And I thought I would do something a little different, and I didn't tell Ashley or Jenny or Debbie this, but I was just sitting here thinking about it. If you have any burning questions right now, or things that you hope I'm going to talk about, questions that you have, go ahead and put them in the chat box now. Like just thinking ahead, like, oh God, I hope she talks about this, or I've never understood that. Might be a good way for me to just kind of see, at least to start with, what people are thinking about. And then obviously, if there's a burning question as we go along, please feel free to put the question in there. Jenny's gonna keep an eye on the Q&A, and I'm all about answering questions when they come in, unless if it's something that seems like it could wait, we can wait 45 minutes from now. I hope to be done in 45 minutes. I have a 1 o'clock patient, so I have a hard need to stop to see a patient. So, all right. I always like to start with how do we get here? right? Why even the word palliative care? Why even the word hospice? Hospice has been a word that's, I think, in most people's experience, has been a little more common than the word palliative care as well. That's been a slightly newer term over the past 20 years or so. So kind of how did we get here? And so certainly not going back to the beginning of time, but looking back to the 1800s or early 1900s, really before 1940, 1950, when we had antibiotics come to the marketplace. But really back then, life expectancy was around, on average, 50 years of age. And I always think that's such a sobering statistic when you kind of just think about that. You were old when you were, 50. Dying usually happened in the home, and very commonly, death back then was due to injuries, acute injuries, people, farm, getting trampled by horses, getting speared, and bleeding out because we didn't have blood banking available then. Thanks, Ashley, for putting that in the chat too. And then certainly infection, right? When you think about all of the epidemics, or you think about somebody suffering an injury and then the wound getting infected and having no synthetic antibiotics, what we are so used to today. And so because of those mechanisms of death, and people died at home, as I said, and because they died at home, I put comfort on here, but I don't know that to be the case. How comfortable was the family? But more than comfort, maybe the better word would be familiar, right? There was definitely more familiarity with the dying process, because it happened most commonly in people's homes. There were some hospitals, but certainly not like what we have today. And so when we look at the end process, right, naturally dying, what it is, that process of dying, what does it look like, right? And that is, and it doesn't matter if this is from a brain disease, if it's from a cancer, doesn't matter if it was from acute blood loss, infection, heart issues, same then, same now. And that is, often we have a process from months to weeks to days where the body gradually is shutting down. Less food, less fluid, to gradually stopping eating and drinking. And as a result of the changes, then people become unconscious and then move into a coma. And back then, there weren't, again, all of the IV medications and even IV fluids. And I always put on here that often back then, and some of you, I'm sure, have seen this illustrated in old movies, old Westerns, or any kind of movie that took place back in this time, where a doctor often made a house call and they saw the person who was dying, and they looked at the family and they nodded their head and they said, "It's time." And the family looked at each other and they said, "It's time." And then if there were neighbors around, if they had even any close neighbors, the word went out. The doctor said, "It's time." And so, again, when I say the comfort with that or familiarity, it doesn't take away the grief and the loss and all of that at all. But when we look at a later date, as dying shifted from home settings to out of the home, then there's less exposure to that. right? And so in the 1950s, with the introduction and the widespread introduction and availability of sulfa and then penicillin, that was a huge shift, huge advance in medicine was antibiotics or were antibiotics and continue to be. But also from the 50s on, improved surgical techniques, improved public health safety measures that helped lead to a decrease in infant and child maternal mortality rates. And so more hospitals, more healthcare types of facilities. And so roughly about 50% of deaths then began to happen in the hospital settings. You know, it's interesting. It's sort of like, you know, babies and birth, right? Went from home to becoming more of a medical procedure, and family often kept in the waiting room. So it's interesting, two ends of our life spectrum. But specific to dying, there was less exposure to how the end might look, right? And as technology, as our knowledge has continued to grow and expand, and all of the things that can be done now, which are tremendous and wonderful, but that began in many ways and has continued to really shift expectations of the medical field of, well, now with all of this stuff that we can do and machines and drugs and stuff, we should be able to cure most everything. And if you can't, then why can't we? Right? So we had this shift from really sort of comfort to, well, cure, which is wonderful if we can. And so when we look nowadays, right, 2025, we can cure some previously fatal diseases, no question about it. Certainly some infections, but people die of infections every day. Certain cancers, especially childhood leukemias, I mean, major advances, wonderful. We still have the same leading causes of death in the United States, which is cardiovascular disease, heart-related deaths still is number one. And then we have cancers. Then we have cerebrovascular strokes, and then neurodegenerative diseases. And then we have COPD, chronic obstructive lung disease, is number four. Right? And so they're the top leading causes of death because we don't have a cure for them. And so with our advances in technology, and I've now been a nurse for a long time. And when I think back to when I, you know, first started, my very first real nurse job was here in Atlanta as a brand new little nurse, newly married, moved to Atlanta from Florida and worked in the open heart unit at, back then, Crawford Long Hospital. And open heart surgeries, coronary artery bypasses were, you know, really, you know, they had been happening for a while before I started, but they were still just so miraculous. And they are, there's no question about it. But from then to where we are now, I mean, the changes are tremendous and wonderful. So with all of the advances, in many cases, not all of them, but in many cases, we haven't actually cured anything. But our medicines, some technology, you know, machines, different things have been able to help prolong someone's life, right? To have more time living with a chronic disease. And so that's why the shift, when you think back to where I started from in the 1800s and up till antibiotics, there were, I'm sure, some cases where people lived to an old age and then died from, quote, old age back then. But that wasn't the most common mode of dying versus nowadays, chronic disease, any of them often is the most common. I listed off the four leading, causes of death here in the United States. And so the question always is on the medical side, for medical providers is, how much do we do? What is the goal of what we do when we're doing things? And so this is just one example of looking specifically at intensive care unit resources. The rate of ICU use at the end of life increases significantly with age and with the number of coexisting chronic illnesses or diseases. A recent study found that as many as 1 in 5 people die either in the ICU or shortly after having received ICU care. So what we see is, and in some ways you would almost think it should be the opposite, and that is, as someone gets older, it's not to say ICU care is inappropriate at all. That's not the intent of this to say, but it is to say, as we've lived and lived longer and maybe have some chronic illnesses, why haven't there been conversations to say, gosh, if this happens, boy, I wouldn't want that. Right? We have that responsibility of, at what point does doing something to somebody help them get back to who they were, right? And so, why we need palliative care and hospice care. Again, roughly 50% of Americans die in the hospital after spending days in an ICU just weeks before their death. But roughly 50% of Americans die in the hospital, as opposed to home. And a home, when I say home could be a personal care home. A home could be a nursing home. It doesn't necessarily mean, a personal house, but out of the hospital setting. So is there a good death? Is there a bad death? Does anybody have thoughts about? Can there be a good dying that leads to a good death? Can there be a bad dying process?
Yeah, I was trying to give a pause to see if any participants wanted to answer, but especially in clinic recently, we've had several families share the experiences they've had of their loved ones being able to pass in their home, in their bed. And I think from those conversations, I think for myself and my clinical role here, I think I would define a good death as being the passing in the way that the person wants to. Being, and for those people, it was being at home, being in their bed and surrounded by their family. And so I think it's for each individual what a good death is.
Absolutely. Yeah. Absolutely. Now the participants can't come off mute, right?
They can put they can't, but they can put something
in the chat or Q&A. Yeah.
So please feel free to do that if y'all want to. We'd love to hear from you.
Yeah, please.
A right or wrong answer.
No, it is just a gut. You know, I've certainly seen bad dying deaths. And for me, a bad dying, an unfortunate, sad, ones that, you know, would stay with me were those settings where family members couldn't get to their loved one in time. They were in the hospital, in the ICU potentially, and couldn't get there. I remember, I mean, years and years and years ago, as a new nurse there in the ICU of a young patient, probably in their 20s, and I forget the circumstances, but he was bleeding and bleeding out as fast as we were putting blood in, and I just remember him looking at me and saying, I'm not ready to die. Please help me. I'm not ready to die. And I was like, oh gosh. And that sticks with me. Yeah, I think many people identify that, you know, a bad process would be or could be when someone is having lots of pain or other distressing symptoms, shortness of breath, nausea, vomiting, and just, you know, they aren't being controlled for whatever that reason might be. So someone is dying, having these terrible symptoms, and families are left with that realization and visualization. And I think that is really difficult to deal with. I don't know if anybody thinks of anything more. You know, a good death, a good dying, you know, could be that there has been some time for resolution. There has been some time for acceptance. Maybe there's been time to see loved ones or good friends that you haven't seen, or, you know, mend relationships that might have been, you know, ripped apart. Debbie Arnold says a bad for her equals interventions that a person had clearly expressed that they did not want, but were being done to them. Yes, I would agree. Thank you for sharing that. And so palliative care, what I started with saying, you know, this terminology that started appearing really in the 2000s, early 2000s. Palliative, to palliate actually means to comfort. And to comfort in the situation where we know there is no cure for this disease. The Latin word pallium actually means to cloak or cover. So I kind of think of putting a covering or a blanket on someone who is suffering in my mental picture there. But it then became a medical specialty that's defined as interdisciplinary care that aims to relieve suffering and improve quality of life for patients with a life-limiting, life-threatening, serious, or terminal illness and their families. So care that aims to help relieve suffering, and suffering is not just physical pain, right? Suffering to me, that word is all encompassing of spiritual and emotional, mental, and physical suffering in whatever form or forms that is. And the whole purpose is if by doing some of the things we do, we can help extend someone's life, but not cure it, are we extending a life that we could help control suffering for them versus, oh, we're just extending someone's life for them to continue to suffer, right? So palliative care really tries to take into account the person and the family as well. It is offered simultaneously with all other appropriate medical treatment. And that becomes important because that is one of the differentiating pieces of hospice care and palliative care. Okay, so hospice care is everything in that first run-on sentence that I have there for you. Interdisciplinary care that aims to relieve suffering, improve quality of life for patients with a life-limiting, life-threatening, serious, or terminal illness and their families. Absolutely. Simultaneously with all other appropriate medical treatment may be the delineating piece with hospice care. And I'll talk a little more about that as well, what that really means. Palliative care nowadays, we have a wide body of research and evidence-based treatments and approaches for pain control and other symptom control. And again, if someone is receiving, hemodialysis to help prolong their life, I can still see them as a palliative care provider. If someone has a cancer and they're receiving chemotherapy, radiation, immunotherapy, combination of all of those, I can see them as a palliative care provider. And again, that's different than with hospice care. And so this is a very classic diagram that we in the palliative care field use. Let me make sure I've clicked it all here. Yep. I never can tell if there's one more flying in piece here to the picture. But basically, what this is trying to show over here on the left-hand side, someone gets diagnosed with a serious illness, or it could be a terminal diagnosis. It could be, a terrible acute, all of a sudden event that happens. Whatever it is that is serious, life-threatening disease at that time. And we, on the medical side, start doing life-prolonging therapy, doing things that hopefully are consistent with what the person would want and wants. And as that is happening, that we also are focusing on the whole person. What are their goals? What are their wishes? That palliative approach can start at the same time as a serious diagnosis of saying, there's potentially not a cure for this disease. We're going to do, what we have that we can do. And at the same time, we're also being realistic about what that could look like. Maybe they call in a specialist palliative care. Maybe the cardiologist, maybe the neurologist is, providing that same focus and approach. And so the two can live together. And what you see as this serious illness, life-threatening terminal illness, what you see, the green part, the lighter green part starts getting narrower and narrower and narrower, meaning there's less and less and less and less, perhaps, treatment options there, right? And this could be 10 years worth. Could be 5, could be 2 weeks. I don't know, right? And as the disease progresses and life-prolonging, life-modulating therapies have fewer and fewer impact, then more focus is, let's make sure again, are we relieving symptoms? Are we having conversations? Are we focusing on the person, on the family in terms of goals and achieving those? So the palliative piece starts expanding. And then absolutely, there will come a time when our Medicare hospice benefit might make sense in the last 6 to 12 months of someone's life. So to have this additional interdisciplinary team providing the same approach, symptom management, psychological, spiritual support for the patient. But now this is very much a time-limited benefit. Okay, so the palliative approach is happening all along. And like I said, this could be 10 years. This could be Alzheimer's disease. This could be Lewy body disease. 10, 12, 15 years, 8 years, whatever it is. When we feel like, based on signs, symptoms, other parameters that are taken into account, that if the disease runs its natural course, that's actually the writing in the Medicare law, the hospice benefit, federal benefit. If the disease runs its natural course, I would not be surprised if death occurred in the next 6 months. Because we certainly all know we are not all knowing. We are not God. I can't tell somebody that they're going to die next Thursday at 1 o'clock. I can say I think we're in the later stage of this, and I think we're talking about months rather than years. But I can't get more specific than that. And then when death occurs, then there is part of the hospice law, the hospice benefit, that now says that hospice agency needs to provide bereavement support for the family for the next year after the death of their loved one. Because what this diagram used to look like prior to the early 2000s was diagnosis of a serious illness, life-threatening, terminal disease, whatever it was. There was no palliative care. It was all light green, treat, 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 do, and then seemingly at times, not every time, but at times, then the medical team came to the person, family, and said, well, we can't do anything more. It's time for you to get your affairs in order. And it was this major shock. What do you mean? We've been doing all this stuff. I thought that this was helping, it was curing. And so then people said, well, now we need hospice. Boom. And so we have seen, and certainly the hope in the very beginning of the recognition of the need to have extra support from a not just focus on the disease, but focus on the person approach. And you would think that would be inherent in all that we do as medical providers, but it's not always. And so types of palliative care, what that means is there's primary palliative care, there's tertiary palliative care. And so in tertiary palliative care, that's what I did for 10 years when I first came to Emory, as Ashley said, helped start the very first inpatient palliative care service for Emory. And we started with about 4 people, 2 part-time physicians, myself, a nurse, and a student chaplain. To now, almost 20 years later, to over 70 providers at all of the Emory hospitals. So tertiary palliative care happens in the hospital setting. Palliative care specialist like myself, right? So I might see someone who's end stage Alzheimer's dementia with, their 3rd or 4th aspiration pneumonia. Or I could see a 35-year-old with a massive intracerebral brain hemorrhage, right? So often in the inpatient / tertiary setting, acute exacerbations of chronic diseases, sudden like the trauma, like the brain hemorrhage, and often short exposure to the palliative care team. I might come and have seen you and might have seen you, your family, 3 or 4 or 5 times, and then you're discharged. Versus now, for me as a palliative care specialist, not that you have to be a specialist, to provide primary palliative care. So for all of my years here in neurology, cognitive neurology, integrated memory care setting, it is seeing patients often longer, right? For years. And so this is more chronic disease management. And so I may not be taking someone off of life support like I did in the hospital setting, but what I may be doing, having a conversation earlier today, was about the importance of talking about, does this make sense to do maybe this test? Does it make sense to do this? Is this consistent with what if the test shows? Right? And talking through, again, with the focus of what is important to somebody in light of these diseases that continue to progress. And personally, I believe that decision-making, medical decision-making, should change as the disease changes, right? Early stage, I might say, yes, this makes sense, this makes sense, this makes sense. Yes, I want to do that. Yes, I would have that surgery done. End stage might be a very different decision, right? And so the importance of having providers that you can talk to about that. And so again, outpatient like here, right? Hospital-based, home care. There are palliative care nurse practitioners that will make home visits. Some of you may have that on board with you. Nursing home, and obviously hospice. And so the example that I was just giving y'all of, I had a conversation with a new patient and her son earlier today. And it was this diagram of what I was saying. We have to talk about the what ifs. And I would do the same thing in the hospital. Say, what if you say, yes, I want to try the chemotherapy? What could that look like? Patients might ask me, well, what if I get really sick from it? Can I stop it? Because I'm not sure I really want to do this, but my family wants me to do it, so I'm going to try it. But can I make a decision to stop something? Absolutely. Right? So almost like when we on the medical side talk about informed decision making, we talk about shared decision making with our patients and families. We'll give you our medical opinion to the very best that we can. We can share with you what an MRI looks like. We can share with you risk of a treatment to help you be able to make decisions, hopefully with our input. But when this part is really skipped, then often there can be very mixed signals, or I've been with patients, especially in the hospital setting, with family meetings, and all of a sudden the primary, let's say, oncologist says, well, this cancer was never curable. And I remember one time I had a son who stood up and threw his chair, and he was like, what do you mean this was never curable? That's why we've done all of this for my mom. I'm like, ooh, something got missed, right? So I know within cognitive neurology here, I know within the integrated memory care clinic, between the physicians, nurse practitioners, and our social workers, we take this part really seriously, because I do think it is one of the keys. Do you understand what it could look like for someone as they progress with their heart failure? what it could look like, what we would not be surprised by with Lewy body dementia, Parkinson's disease, whatever it is. To try as much as we can. Prepare. Not that when something happens different or acute, that it means everyone just goes, oh, okay, yeah, I really knew that was all going to happen and I'm fine with it. No. Preparing doesn't mean that, but it means, oh, yeah, Debbie did mention that could happen. Ashley, Jenny said when last time we talked that, she wouldn't be surprised if we didn't start to see this. So I think that is that whole component of as much as possible trying to understand, for us to give the information. Even when it comes to very simple things that we take very much for granted on the medical side of things. Oh, you're 55, it's time for your colonoscopy. Right? And your loved one maybe is 58 and they're in the end stage of Alzheimer's dementia. And the primary care says, well, colonoscopy. And you're like, what? No, we can't do a colonoscopy. They can't drink the prep. They're going to have diarrhea, all of those things. So not everybody really thinks through some things that seem pretty simple. Well, like, why wouldn't you do that? You might have done it 10 years ago. So what is hospice care? It is philosophy of care to assist those in the end stage of life. Did originate in England. The first hospice in the United States was in New Haven, Connecticut. Dame Cicely Saunders from England came over and helped start that. 1976. And this 3,500, I have not double checked it recently. It's, I would guess probably more than that in terms of hospice programs or hospice agencies. Again, the hospice model of care is palliative care. But when we look specifically in the United States, Medicare hospice benefit law that was signed into law in 1982, 82 or 84. It is an interdisciplinary model philosophy of care to provide physical, psychological, social, spiritual support, symptom relief, for those who desire no further curative measures. Oops, sorry, I'm twitching. And that the medical providers, specifically physicians right now within the hospice world, still are the ones who certify a patient. They would say, I think based on every evidence that I'm seeing, maybe some lab work, weight loss, 4 hospitalizations in the last 6 months, aspiration pneumonia. I would not be surprised if this person died in the next 6 months, if the disease runs its natural course. And so for us in the United States, there is a time frame. This is an insurance benefit. When you think about it purely from that approach, designed for 6 months to maybe a year if the person continues to show decline. Because Medicare is going to give the Medicare money to the hospice agency to have a physician, a nurse practitioner, a nurse, a medical assistant, a tech, a social worker, all the medicines somebody needs for whatever their diagnosis is, a hospital bed maybe, oxygen maybe, right? So this is money that's going to help manage whatever that patient needs. And so there's a time limit to it. And that's really the key difference with palliative care. I see my patients here. I've been here 9 years. I still have some of my original patients. I haven't cured any of them. I wish I could. I think I've helped manage some symptoms pretty well and have lots of conversations. But we wouldn't provide hospice support with a whole team for 9 years. In other countries, hospice and palliative care is viewed the same because it's not necessarily tied to an insurance benefit. Okay, so the hospice team, as I was mentioning, some of those team members, they do supply medical equipment that is needed for the hospice diagnosis, drugs, medical supplies. And again, the whole goal is not about you're dying, you're dying, you're dying, you're dying, you're dying, but how can, in whatever time period, we help emphasize living quality, symptom management, doing things somebody might want to be able to do if at all possible, help support the family. And so Medicare and Medicaid have specific guidelines for different diseases as to what things, lab work, different types of diagnostic testing would be helpful for the physician to say that this person, in my opinion, if the disease runs its natural course, has that 6-month prognosis. And the patient and or their surrogate decision maker is choosing and realizes the philosophy is we aren't seeking further additional curative type of care. And so I don't think any of these, again, when you think about the leading causes of death, these are very common hospice diagnoses. And the benefits, of our hospice benefit, and it is there and it is often underutilized. The hospice benefit was not intended to just be for somebody who, has 2 days to live. I mean, it's great if it gets started even then, because it also means the family gets the bereavement support. But the benefit was to have a support network for a period of time of 6 months, not just the last 2 weeks of someone's life. But because it's often, for a variety of reasons, not used till very close to the end of death, and a lot of times people associate hospice with, well, you're going to die. Oh, that's for when you're dying. Or my loved one started hospice care, they gave him morphine and they killed him. They died. There are different levels of care for hospice. The most common is happening in people's homes, again, wherever they call home. Nursing home, assisted living, memory care, personal care homes, or home. Right? That is the most common. And the reason for that is the majority of people surveyed will say, I want to die at home. Not everybody feels that way, though. Right? Not everybody, different cultures, that it's really not acceptable to die in the home. So I never want to say that everybody wants that. They don't. But routine home care is the most common level of hospice care. Inpatient hospice care, like going into a hospice facility or a unit that might be even inside the hospital, like at Emory, is really intended for very short stays. People don't go and move into a hospice house and live there for 6 months until they die. That doesn't happen anymore. It's usually very short term to try to manage symptoms. Respite care for caregivers. So let's say the hospice team has been coming to the house and now you say, you know what, I've got to go, my granddaughter is graduating or getting married and we're going to go out of town. My loved one who's receiving the hospice care can't go. And so the hospice would get them set up, usually in some type of nursing facility for that period of time to allow for respite for the family member. Continuous care is probably the least utilized because it's a tough one, but what it is used for is for someone who may be having an acute exacerbation of some symptoms, or maybe in the, actual actively dying stage with symptoms where the patient, the family still wants to be at home, but maybe they need an extra layer of care. So the hospice would provide a nurse or usually a combination of nursing assistants to be in the home for 24 hours. But again, as we know, routine home care is not a hospice person coming and being in the home 8 hours a day. No. So dying at home, my pictures are very different from the one I showed you in the hospital setting. And this is actually my dad and my mom. This was 7 years ago. This was probably the day before Daddy died. So at home, he died from chronic kidney disease, had made the decision for no dialysis at the age of 87, which that was what we all felt was in his best interest as well. And so that decision was made in January of that year, and this was November of that year. And we started hospice about August. He was having some symptoms, and my mom needed that support down in Florida. And so he wanted to be at home. He wanted to die at home. And that is what happened. So it was as good of a dying as it could be. I think this is my last slide here, and then we'll see if there are any questions. But hopefully, if you needed to sort of see side by side the differences, chronic, progressive illness, but also maybe there's additional curative things, or maybe I'm getting medication, that is really, really, really expensive, but helps control my symptoms that a hospice couldn't afford to do. Both very much focused on symptoms and quality of life. And I did put a little bit here. I think you've had other classes talking about documentation tools, but advanced directives and then medical orders. So advanced directives, legal documents where, like a living will, although nowadays that has really, for the most part, been replaced by healthcare powers of attorney proxies, where me, the person, can, in advance of something happening to me or my losing the ability to make my decisions, can put down on paper my wishes, where I could name somebody to say what I would want. And then there are medical orders. And so when people complete advanced directives, which is wonderful, and talk about them, the medical team still has to take those wishes and turn them into orders, because everything within the medical system works off a doctor's orders. And so the physician orders for life-sustaining treatment in Georgia, that is what we call it, the POST form or POST program. Other states call it the MOST. some it's toast, they're different things, but basically they're all the same. It's an attempt to take someone's preferences. No, I wouldn't want to have that done. No, I don't want CPR. Like my dad, when he said, when God says, come on home, I'm gone. I don't want anybody to try to restart my heart. That's the very first box here. But if a physician doesn't turn that wish into an order, and someone's in the medical system, it won't be honored. It's a gap in our system. People may say, but I put all of that in my advance directive. Yes, you did. And good for you. But we still have to turn it into an order. Those who know me know this is one of my most favorite quotes. Life, and we don't know who said it, life is not measured by the number of breaths we take, but by the moments that take our breath away. And I think that's true. Often the most important things are moments that bring memories. And that moment could be a picture, it could be a song that comes on, it could be a food, a smell, that are so important for us to hold on to. So I'm going to stop sharing and see if there are any questions or comments.
As in Debbie, that was incredible. And I especially really appreciated your slide at the end that had the difference between advanced directives and medical orders. I think that's so
Yes.
important for families to have an understanding of understanding what has to happen on the back end.
Yeah, because we barely understand it. Why do we expect lay people to understand it?
Right. But I really, really liked that a lot. Thank you.
You're welcome.
I think I just saw one question.
I did show the chart between palliative and hospice care. I can do that. Let me go back one more, two more. There we go.
There you go. Yeah. I really like that slide as well, Debbie. It's very well done.
Yeah, I like that one too. I found it. I was like, because I've typed one out, but I like the colors too, and it was easy to see. Anne says, I understand that hospice is the last 6 months and is tied to insurance. I'm not sure I understand how palliative care is initiated. Great question, Anne. In the hospital setting, in the tertiary care setting, if let's say you're there with a loved one or it's you and you would like to speak to a palliative care specialist, you ask your primary team managing you, or if it's your loved one and it's maybe cardiology or it's hospital medicine, you could say, we would like to speak to the palliative care team here. You can initiate it. And so we always talk to our families about if at any point during an acute hospitalization, you want to have an expert in this area come and talk to you, you may request it. So often the primary hospital team or specialist, whoever it is, will request a palliative care consult. Okay, that's in the hospital setting. In the outpatient setting, often your nurse practitioner or PA or whoever you're seeing, or physician provider, may say, at this point, you may find it helpful to have a palliative care provider come to the house to see. There's not a whole team in the outpatient world. And that's the difference from inpatient. It doesn't translate quite like it does. And because it's not a benefit paid by the government. So let's say I could come to your house and do a palliative care consult. I would submit a bill to Medicare as any other specialist, like a cardiologist. and I would get paid through Medicare or United Healthcare, whatever the insurance is. Many times, the way that home palliative care is provided is actually through some of our hospice agencies who have another side to their business, where they have palliative care, often nurse practitioners, who will come to the home maybe once a month. It's not, like I said, the whole team at all. But sometimes maybe somebody's saying, you know what, I want to finish up, this radiation because it's going to help the tumor not break through the skin. We know there's not a cure. And once we're done with this palliative radiation, then we'll be ready to start on hospice services.
Thank you, Debbie. Is it possible to put the advanced directive so
Yep.
multiple people are asking for
Yep.
specific
And we
slides.
can share my slides. Somebody also asked about sharing. Can y'all send them out to people?
Can we do that, Ashley?
I will check and see. I'm not
Okay,
positive.
I'm not sure with webinars if you
Emails that we need.
do that.
But everybody to remember, there's going to be the link that Ashley put in. You can
That's true.
watch the presentation. It'll be posted in a few days.
June, you have a great question in here. You said she has had an experience with EMS personnel not knowing what a post is. Are there any requirements in the EMS training that include knowledge of a post?
I actually know the answer to
I
that.
was gonna ask you, Ashley, if you did, is there a requirement for training?
There is, it's a relatively new requirement. So there are folks out there who've been in practice for a long time as EMS professionals who may not be as familiar. But I happen to know that because I ran into the same issue with a family member of mine. And they had gratefully knew what the post was, but they had no idea what to do. Once they knew what not to do, they didn't have much of a clue what to do. So we had to figure that out together.
Yeah. Yeah, no, great question. And I'll try to do a little more research about it because that is a huge need. Again, we come up with all these things, but how does the information get disseminated? Someone else asked about someone with a urinary catheter and they're in hospice care. Can they have a urine specimen sent for lab testing to identify the organisms to enable selection of the appropriate antibiotic? Can they go to the hospital for care if the infection becomes severe? And the answer to both of those things is yes and yes. I mean, there's nothing in the hospice benefit that says no lab work, lab can't be done at all. If someone's receiving hospice care and then they go to the hospital, like maybe for an infection, or maybe there's a fall at home and now there's a fractured hip. Usually what the hospice agency will do is have you sign off. The person will come off of the hospice benefit so that when that person is in the hospital, Medicare then covers the hospitalization. And then after coming out of the hospital, sign back up with hospice care, because hospices don't just, they're hamstrung by money. And that's the reason for that. It's not that they don't want to, care for the person. It really is about money. Now, if that person with the catheter, let's just continue to use that example, has multiple infections, and every time you want them to go to the hospital, then probably the hospice philosophy may not be the right philosophy, because a urinary tract infection can be treated at home. If it's severe enough to need hospitalization, maybe one time, but if it's over and over, then there'll be a conversation to say, this may not be the best philosophy at this time. All right, y'all, I have got to go. Thank you so much for allowing me to be with y'all.
Thanks, Debbie. Really
Thank
appreciate you
so
being
much,
here.
Debbie.
And
Amazing.
thanks
You are
to
so
everyone.
welcome.
Thanks for everyone for being here. We will have this recording posted in the next couple of days.